everyone, the new speaker, Thierry Deltombe, and we talk about the spastic foot and the big title. So you can.
Thank you. So the aim of this retrospective study was to assess the effect of nerve block and most of all of neurotomy on spastic co-contraction. So for a long time we know that spasticity is not the only spastic muscle overactive type, and we more and more have a look at the spastic co-contraction, and I would like to highlight the work that have been done in Toulouse with Philippe Marc teams about spastic co-contraction, because we know now that spastic co-contraction is much more related to limitation in function than spasticity in itself. I mean spasticity, velocity-dependent increase in muscle tone in passive assessment, while spastic co-contraction is inappropriate muscle activation during active movement. And so our question was, we know that when we look at a study dedicated to neurotomy, all studies use mass scale, modified Ashworth scale, which is a passive scale for spasticity assessment. Only 2 use Tardieu scale. 7 deal with active ankle dorsiflexion, active movement. 6 by means of Hermer-C scale, and we all know the limitation of this scale in traumatic brain injury and stroke patients. And only 3 deal with active range of motion as measured by ankle. So improvements were observed also with active range of motion after neurotomy, but those studies all include patients with and without previous tibial anterior activations. So if you have no tibial activation, you are not able to measure improvement in active dorsal flexion. So we mix those different type of patients. So no study assess specifically triceps spastic co-contraction, neither active ankle dorsiflexion in patients with active function before surgery. So to be sure, you know what we are talking about. This is an Ashworth and Tardieu scale. I perform a passive active range of motion, then mobilization at fast speed, which is the catch, and I measure the angle of catch. And after that, I ask the patients to perform an active elbow extension to measure the active range of motion. So, of course, I will deal with a spastic foot, but I have this image at the upper limb, it's the same. So we measure this patient, Ashworth 2, moderate resistance passive range of motion, Tardieu 2, a catch and a release without clonus. And I will measure passive range of motion, 180, the angle of catch, which is XV3 100, it's an angle. And after that, I will ask her to perform an active range of motion, which is 140. This is how I monitor my spastic scale, A2T2, and those passive, catch, and active. I let you have to remember this. And here you can see at the spastic foot, when I ask her to dorsiflex, actively dorsiflex her foot in flex position for the soleus, she is able to do it, but you can see a slight fibularis co-contraction. While she is in extended position, she is not able to actively dorsiflex her foot. She do an inverted movement due to a gastrocnemius co-contraction. Okay. So we know what we are talking about. So the objective was to assess the effect of diagnostic nerve block and most of all of neurotomy on the active dorsiflexion, ankle dorsiflexion, as an indirect assessment of the triceps co-contraction, as we need for a full co-contraction assessment, electromyography, and we need dynamometers. We are not in a gate lab, but in clinic, so we don't have the material at that moment. So for this, we perform a retrospective study with the Tardieu scale in addition to the mass. And we measure two angles, the paresis angle, which was our primary outcome, which is the passive range of motion minus active range of motion, okay? The paresis ankle Z, which is correlated to the tibialis anterior weakness and to the triceps co-contraction as an indirect measurement of spastic co-contraction. We also measure spasticity with the spasticity ankle, which is a passive range of motion minus catch. So passive minus active and passive minus catch. This was a 2 ankle, and we did perform this into knee position. So we did perform a retrospective study with all the patients that I collect until the beginning of my career on an Excel sheet. And we review the inclusion criteria were spastic equinovarus foot, improved after diagnostic nerve block. The patient must have a 10 degrees, minimal 10 degrees, active ankle dorsiflexion improvement, or possible active dorsiflexion of 10 degrees, before or after block. If known, they were excluded. A passive ankle dorsiflexion of more than 90 degrees, which is a neutral ankle, so no fixed contracture. More than 80 years, operated from tibial neurotomy, and at least 1 clinical assessment within 6 months after neurotomy. Exclusion criteria were no active ankle dorsiflexion and associated tendon surgery except 2 flexors tenotomy, which to our opinion doesn't impact so much the patient. And so we review 317 operated patients from neurotomy. We finally select 46 patients who fulfill the inclusion criteria, no Achilles tendon lengthening, good tibial activations. And all those patients were followed during the 6 months post-surgery, and 26 patients had a longer follow-up of more than 1 year, after 1 year. And so if you look, we performed 2 analyses. The first one in the 6 months following surgery, and with a less impressive number, 24 more than 1 year. As you can see, mean age 46 years, always the same, it's young patients. Onset between stroke and surgery is 88 months. Mean follow-up was 3 months in the first group and 1 year in the second group. Mainly stroke patient, and importantly, all the patients benefit from soleus neurotomy, and 72% from TP neurotomy, tibia base posterior, and only 27% benefit from a gastroc neurotomy. So in a neurotomy at the soleus in every case, and at a gastroc in 27%. So not every patient benefit from gastroc neurotomy. And so if we look at the active ankle dorsiflexion, there is a lot of results, but I will highlight those in red. The ankle active dorsiflexion was mean 90 degrees before, and was improved at 100 degrees, which is plus 10 degrees in active dorsiflexion 1 year after neurotomy. So an improvement in active dorsiflexion, while the testing stays the same all along, but we know that it's not a good scale for those assessments. If we look at the paresis angle, which is a passive range of motion minus active range of motion, we see that before surgery, the paresis ankle was 10 degrees. Normally, it must be 0 in every case. I hope that everybody here has 0 degree of paresis ankle. So it was 10 degrees before, slightly improved after block, but also after neurotomy, 6 months, and also after neurotomy at 1 year. So statistical improvement in paresis ankle when the knee is positioned in flex position, assessing soleus, and we know that all our patients benefit from soleus neurotomy. If we look at the same parameters with the knee in extended position, assessing soleus and gastrocnemius, we see that the paresis ankle was a little bit more, 20 degrees, and 6 months after surgery it was slightly improved, but it was not improved 1 year after surgery. So no statistical improvement when we test soleus and gastroc, but only 27% of the patients benefit from gastrocnemius neurotomy. If we look at the spasticity angle, another way to assess spasticity, we observe 25 degree by mean before. Normally you should be 0 because the spasticity angle is passive range of motion minus catch. Dramatically decrease at 0 after block, after neurotomy, and 1 year after neurotomy. We also demonstrate a great improvement in modified Arthur scale, and also in the Tardieu score, which is less interesting. So with the knee in flex position, we also demonstrate a dramatic improvement in spasticity assessed by Tardieu scale. And the same for when we assess soleus and gastroc in extended position. The spasticity angle moved from 27 to 15. It was not 0, but it was improved. And the same for the mass and for the Tardieu score. So as a conclusion, with this retrospective study, including patients with active movement before the intervention, we demonstrated a decrease in spasticity angle, which confirmed what has been previously demonstrated with mass scale, from 30 to 0 degree in flexed position, and from 30 to 15 in extended position, but we operate less gastrocnemius nerves. And the most interesting to our opinion was that the paralysis angle was also decreased from 10 to 0, normal value in flex position, and from 20 to 10 degree in extended position. So the reduction in paralysis angle supports the hypothesis that neurotomy is also effective on spastic co-contraction. I fully agree that it's an indirect measurement as we don't have any EMG or dynamometers. Reduction with knee in extended position is less impressive, probably because we don't perform neurotomy at the gastroc systematically. And this supports the need for a prospective study with EMG analysis and dynamometers, because as I'm a big fan of neurotomy, it's a wonderful tool. I'm fully convinced that it's effective on spasticity. I have clear doubt about the effect of spastic dystonia. I'm a little bit reassured that it's probably effective in spastic co-contraction. But as those physiopathologic conditions are different in those different types, we think we have to be careful and to assess this in a prospective way. Thank you for your attention.
Thank you, Thierry. Some questions, some other experience? Yes, maybe one. Dominique, si tu veux, vas-y.
Just to push you a bit, Thierry, a bit further. Finally, the gains were not so huge, 10 degrees, except for spasticity angle with the knee flexed. And I guess that because this is a retrospective study, you were the only observer and not completely blinded, and maybe very enthusiastic about about the results of your treatment. So I would be more cautious regarding the interpretation of your data. What would you like to say?
Thank you. But, I think I was cautious because I assumed I clearly mentioned that it was not a proper way to assess spastic contraction. But yeah, okay, it's only 10 degrees, but it's 50%. Okay, it's half of the way. So, okay, it's unblind because I'm the usual assessor. It's retrospective. There is, on a methodologic point of view, some point to debate. I fully agree. But before to start something prospective, and before to continue to perform surgery in such case, we would like to have some matter to start.
That's
the
true. This
function.
is 50%, but this is only 10 degrees. And
Yes, but yes.
So
what
the
is really the accuracy of your assessment tool?
Oh, I think the Tardieu scale.
Maybe 10 degrees?
Normally, we say 5 degrees. When I measure at 5, 15, 10, not every degree, but
I think there
that's
is
a scale.
a specificity for the ankle. It's really easy to have the zero because it's a normal angle of the foot, and the difference of 10 degrees where we run is really clear. It's really easy to measure 10 degrees of difference in the ankle, I think.
Yes, but would you like to continue to use mass scale as in FDA study, which is not sensitive to scale and not more reliable? So
I think as a function tool.
you're right. But when you use Tardieu scale and the ankle for a long time, as it's my case, when I see patient back in consultation, when chronic patients, I don't see the result I have before. I measure my patient and then I come back to my dossier, and I'm usually surprised that I'm not so bad when I see a patient 6 months later. So,
François Passeyer.
Yes, Thierry, thank you so much. I just want to open a door here because each time we present this kind of result, we see that with monoarticular muscles we have good result and with polyarticular muscle we don't have. And each time with gastrocnemius we see that we don't have any results, and maybe it's time for us to separate, and I discuss this very, very often with Bernard, the monoarticular muscles and the polyarticular muscles. I think they are not working during the gait and whatever the function. They are working differently. They are not constrict in the same way, and the monoarticular are stronger, they have more spasticity. The polyarticular maybe are weaker, and the contracture open very, very sooner than the monoarticular muscles. And that's why maybe in our studies we have to think differently when we are assessing monoarticular muscle and polyarticular muscle, because we don't understand exactly how they work, polyarticular muscle, I said. So I don't know if it's time to have this discussion altogether, but each time it's the same for brachialis and biceps, it's the same for rectus femoris, for the hamstrings and that stuff. I don't understand how that works. And each time we have a different, results when you consider monoarticular and polyarticular muscles.
I even wonder if it's only not only a question of monoarticular or biarticular, but a question of muscles. For all those who do toxin under ultrasonography, I'm always you always see that you have much more spastic myopathy and muscle change in the gastroc, and especially in the gastroc lateral, even before toxin. When you look at ultrasonography to the gastroc lateral, is always white with hyperechogenic signal, while the patient was not treated before, yes. And the gastroc medial is less, and the soleus is still. That's the reason why we do not treat so frequently gastroc, because we suspect, but it's clinical impression, that they are not really spastic, but they are much more myopathic, and we prefer to lengthen it instead of performing neurotomy. And we also assume that patients need gastroc for propulsion, and we don't want to weaken them too much, and we prefer to let 10 degrees of paralysis ankle, but to keep a little bit of propulsion. But the question will not be resolved until we don't use gait analysis and dynamometric and electromyography assessment before, after.
Célia?
Oui. Je reviens un petit peu sur ce que disait François. La question que je me pose, donc c'est surtout des hémiplégiques, si j'ai bien compris,
yes, yeah.
avec comme difficulté la capacité des patients à relever activement leurs pieds, surtout genoux tendus, par rapport à genoux fléchis après une neurotomie du solaire. C'est ça?
Avant aussi.
Avant et après.
Ouais.
Mais on a vraiment l'impression qu'il y a un problème de commande, de sélectivité de la commande. Je ne sais pas si la sélectivité de la commande d'un hémiplégique genou fléchi est la même que la sélectivité de la commande sur les loges antéro-externes d'un hémiplégique genou tendu. Et je ne sais pas si c'est qu'une question de longueur de la loge postérieure. Est-ce qu'il n'y a pas autre chose dans la commande en fonction de la position du genou qui changerait? C'est une question que je vous pose.
The solution is at the physiologic level. When you have a patient on the table very clonic, and he is walking quite normally because he don't have any co-contraction, and sometimes you have a patient without any spasticity velocity dependent increase when you examine it on the table, and when he's walking he has a lot of echinovarus deformation due to hypertonia. So it changed from one patient to another, and we have to work on the physiopathology. For co-contraction, we speak about presynaptic inhibition of the antagonist, and we have 1A, 1B reciprocal inhibition, and those mechanisms. We have to better understand what is responsible for those different types of spastic muscle overactivity.
Not to defend Thierry, but just to say the experience that we published with Paolo Zerbinati and Franco Molteni several years ago about the correction of echinovarus foot, and we measured with gait analysis, so it's an objective measure. And we saw that after lengthening, the modification of the active dorsiflexion was nearly 7 degrees, so very small and measured, but the difference in gait speed was 25%. So, in my opinion, we have to be careful because small modification in the angle may represent a big modification in the activity of the patient.
I was going to say similar, because even if your active range of motion doesn't change much because they don't have strength, when they heel strike with a gastroc and soleus lengthening, they will have weight bearing and their V1 will get much better than just 10 degrees change. It might be 30 degrees. And many of them will still walk with an AFO when they're in distance. Yeah. So it's a huge difference just to get the heel down. But I was curious, most of the patients, when you examine them, they can get to neutral with the knee bent, most of them with the knee extended. So why aren't you trying more gastrocnemius?
Neurotomy, you mean?
Yeah.
Because it's because we suspect for a long time that gastric neurotomy will induce more risk of secondary retraction, because you induce a denervation, and every denervated muscles can shorten. And so that was our feeling at the beginning, but maybe we have to review all our neurotomy and to see if we perform more lengthening in the secondary phase. And we need propulsion. Sometimes when you do a neurotomy at soleus and gastroc, the patient is weak with a lack of propulsion in the beginning. So usually we perform block, and if the patient is happy with after soleus block, we don't do a gastroc. But the message is also that the spasticity ankle was abolished when you assess the soleus. Yeah. So the question is neurotomy effective on spastic contraction? As we completely correct the spasticity angle at the soleus where we perform neurotomy in each case, even after 1 year, probably yes. We have to start a prospective study.
Thierry, il y a deux choses que je ne comprends pas. Tu dis que le gastrocnémia, c'est la propulsion. Voilà, pour moi, ce n'est pas un muscle de la propulsion.
Gastroc is not a muscle for propulsion.
Ce n'est pas un muscle de la propulsion. C'est un freinateur et c'est un fléchisseur de genoux. Donc je ne vois pas le raisonnement. Et la deuxième chose que je ne comprends pas, je trouve ça très bien tes résultats, je trouve qu'on ne peut pas en tirer des conclusions, parce que comme l'ont dit les collègues, ce qui compte finalement, c'est ce qui se passe dans la vraie vie. Et donc, et donc je trouve que c'est très compliqué, sur des examens comme ça, que je trouve passionnant par ailleurs, d'en tirer des conclusions, parce que ça peut complètement nous fausser dans notre raisonnement.
Yeah, but, okay. Philippe said that we need more than those examinations. We need to see the patient in his real life in the gates, of course. But it was not we may review gait speed of all those patients. We have data, but we would like to focus mainly on the spasticity ankle and paralysis ankle. But of course, most of the patients are improved functionally in gait speed and foot stability. And of course, I don't treat a spasticity. I treat a patient with spasticity to improve function, and I'm using gas in every case, of course. So it's only a part of the retrospective assessment of the patient.
Thierry.
But it's interesting that you say that gastroc is not useful for propulsion. Quel est le muscle qui sert à la propulsion? Which muscle is most useful for propulsion?
les rares cas, quand tu as un déficit Strumpel-Lorrain. Les Strumpel-Lorrain, ils sont déficits de fibre de hanche.
Yes, but
Mais en soi, le gastrocnémien, j'ai jamais vu un patient sous prétexte qu'on ait fait un bloc. J'ai vu des où qu'on ait, il n'entraîne pas le phénomène de la propulsion. Qu'il intervient dans la stabilisation du genou, ça c'est une certitude. Parce qu'on voit bien des gens, tu leur allonges ou tu leur neurotomises des gastrocs, tu peux avoir des déstabilisations du genou. Mais sur la propulsion, pour moi, c'est tout son mamus propulseur.
But when you have a talus and the patient is working only on his heel without forefoot contact, quand un patient marche sur le talon et qui n'a pas d'appui antérieur, he has no propulsion. You know, the lack of propulsion in CP children, for instance, with hypercorrection, it's well known. You need also the triceps also serve to the propulsion.
Enfin, on sait très bien que nos patients qui n'ont pas de triceps, il y a quand même plein de patients, on a plein de patients, les CMT, on en parlait tout à l'heure, zéro triceps, les polios, il y en a plein qui ont zéro triceps, ça n'empêche pas d'avoir une déambulation.
Yes.
Ils arrivent à démarrer. Donc ça dépend de ce quoi on parle, ça dépend de ce qu'on appelle, tu vois, le côté dynamique. Pour marcher, pour la propulsion, en tout cas pour la marche, ça dépend de ce qu'on veut dire propulsion. Si c'est la marche, si c'est démarrer et marcher, c'est quelle partie du cycle de marche?
Yeah, but maybe you are weak, but if maybe some patients need the shortening for stability and for walking. That is it a passive propulsion or an active propulsion, whatever. But when you overlength the Achilles tendon, you can see that on a dynamic point of view, your patient is worsened. No? Quand tu hyper allonges ton triceps, tu vois que sur le plan dynamique, ton patient est moins bien quand même.
Je pense qu'il faut distinguer le tendon d'Achille et le gastrocnémien. On parle bien des gastrocnémiens. Quand tu allonges un gastrocnémien, ça rejoint le problème des mono et des biarticulaires. On se fout des gastrocnémiens. La preuve, c'est que j'ai fait énormément de transferts des gastrocs, 1, 2, je l'ai repassé et tout. T'as pas un dame de déficit, c'est exactement biceps et brachial. Donc je pense qu'il faut qu'on raisonne différemment si on raisonne que gastroc comme tu l'as fait.
Ok. When you are working with talking with a French guy, you never win. So the same in football. Oh. But I love you, Philippe.
Yes.
So je te pardonne de grand cœur.
Thierry,
Me too. On a au moins un point commun.
Thierry, another question. Maybe it's all the same question. What do you do if you, during surgery, you find a gastrocnemial retractary? You make the lengthen when you leave alone. You do lengthening and you don't do neurotomy.
Yes. We try to preserve gastroc, and if we have shortening, we prefer to lengthen, especially for the long-lasting effect, because we want to perform only one surgery for the permanent solution. So, but it's not scientifically based; it's team-based. So.
Une remarque et en même temps une question que j'aimerais partager avec Bernard Parat. On a parlé de myopathie spastique et de la réaction des gastrocnémiens et du solaire à la toxine botulique. Mais est-ce que la réponse ne serait pas dans leur architectonique différente? Est-ce qu'il n'y a pas matière à creuser là-dedans?
It's a question for Bernard, but I would highlight that I'm always surprised that when you have a traumatic brain injury patient without severe hypertonia, after 1 month in intensive care unit, you have an impressive tricep shortening. So it's not only a question of architecture; it's also a question of what happens in those triceps. You have a spinal cord injury patient for 3 months. You have no fixed contracture. But a traumatic brain injury in coma, in 2 weeks, it's over. So something happened. We have to search on this, on the muscle change in those patients.
Moi, je suis très heureux de cette discussion. Donc, je te remercie, Thierry, d'avoir présenté cette communication qui nous impose une réflexion un peu plus ouverte que ce qu'on a l'habitude de dire, puisqu'en fait, on ne sait pas trop. Pour répondre à la question d'Alim, je crois que l'effecteur musculaire est intéressant à regarder dans sa structuration. Parce qu'effectivement, vous avez parlé d'aponévrose, vous avez parlé de fibres musculaires, vous avez parlé de compartiments, vous avez parlé de deux muscles qui n'en est qu'un quand même, hein, c'est le triceps sural, pour faire l'ensemble d'une propulsion. C'est largement insuffisant quand on imagine, Romain, vous avez montré les dissections qu'on fait régulièrement avec lui, eh bien, on s'aperçoit quand même qu'il y a énormément de muscles, et moi je plaiderais pour la propulsion, pour une grande part, c'est ce qu'on est en train d'essayer de montrer en analyse quantifiée de la marche avec des finoyeurs, dans le long fibulaire. Le long fibulaire, c'est probablement un propulseur du premier rayon de façon extrêmement importante. Et puis, il n'existe pas, en fait, je suis désolé, je te l'ai déjà dit, François, que le muscle soleus, ce n'est pas un muscle monoarticulaire. Et c'est la particularité du pied que de ne pas avoir de muscle polyarticulaire, justement pour s'adapter à toutes les circonstances des sols inadaptés. Donc en fait, toute cette réflexion nous montre bien qu'on a encore à regarder ce que c'est que l'effecteur, comment il est conçu. Il faut reprendre des anciens travaux. Et c'est vrai qu'on est très intéressé avec Philippe sur le concept même de la construction du muscle gastrocnémien avec deux chefs. Mais chacun de ces chefs a plusieurs compartiments et que ces compartiments n'ont pas les mêmes objectifs histochimiques lors de la marche. Et il suffit de reprendre un peu les travaux très anciens de Winsort, de Segal, qui ont bien démontré ça par rapport à ce fonctionnement structurel musculaire pour répondre à Alim. Donc c'est tout ça. Moi, je suis un peu surpris, j'ai plein de questions par rapport à ça. Le tibial, la neurotomie du tibial, par exemple, vous faites les deux compartiments du tibial systématiquement? Est-ce que là, à chaque fois, il y a eu les deux nerfs du tibial qui sont destinés à la partie ventrale et à la partie dorsale du soleus qui ont été traités?
Usually we perform normally a ventral neurotomy because the dorsal is usually when you do a nerve block of the ventral part, the more superficial part, it's usually enough. That's the one we do in selective block. That's it.
Et alors, il faut se poser la question, Thierry, pourquoi il y a une partie ventrale?
Yeah, tell me.
Je crois que c'est... En fait, l'idée, c'est de dire on est construit comme ça. Et pourquoi on est construit comme ça et à quoi sert chaque compartiment? C'est ce qu'Antoine a essayé de vous montrer. C'est vrai que nous, on rigole, on rit avec Antoine quand on a anesthésié ce singe-là, qu'on l'a curarisé, et quand on voit qu'on fléchit la hanche, eh bien en fait, qu'on fléchit la hanche, pardon, les orteils se plient, quoi, alors qu'il n'y a plus de fibres musculaires. Par contre, il y a des fascias, il y a des aponévroses qui imposent le mouvement déjà. Et donc là, on élimine le concept neurologique. Est-ce que ça te convient, ça? Donc il faut revenir à cette structuration musculaire, peut-être avant de voir le concept neuromusculaire. Voilà.
Vous voulez vraiment que je cours, hein?
Pour aller dans ton sens, Bernard, c'est pour ça que j'ai parlé d'architectonique musculaire et non pas d'architecture.
If torture is over, okay?
May I?
No.
May I just add one suggestion? It's really important to improve our way of thinking, and Bernard and other colleagues did a lot on this way as regards physiology, anatomy, etc., etc. But once we better understand things, there is a big way to do before proving that a given intervention has an impact to the field, improve patients with a high level of proof. And my feeling is that we do need high level of proof. Thinking is very interesting. Discussing is really interesting and funny, but we need proofs.
And I need money to prove it.
Thank you. So,